In this video, we'll be talking about the anatomy of the diaphragm, its structure, location, and key functions. To do so, we will start with a brief introduction, followed by detailing the descriptive anatomy of the diaphragm, its anatomical relations. We will tackle the vascularization, innervation, and lymphatic drainage system, some clinical applications, and finally a brief conclusion to summarize all the key points. The diaphragm is a musculo-aponeurotic partition separating the chest, thorax, from the abdomen. It is traversed by the esophagus, blood vessels, and nerves. It is the essential muscle for respiratory dynamics. Let's detail now the descriptive anatomy of the diaphragm. The diaphragm forms a double dome, with an inferior concavity of unequal height, with the right dome being higher than the left. In forced expiration, the diaphragm reaches the fourth rib on the right and the fifth rib on the left. And during inspiration, the domes descend by two intercostal spaces. The diaphragm is formed by a peripheral muscular zone, formed by a series of sternal, costal, and lumbar bundles, and a central tendinous zone, known as the phrenic center. The muscular bundles of the diaphragm can be subdivided into three portions: a sternal portion, a chondrocostal portion, and a lumbar portion. Let's detail now every muscular bundle of the diaphragm, starting with the sternal portion. This is represented by two bundles that stretch from the base of the xiphoid process to the anterior border of the phrenic center. The two bundles define an avascular opening, known as the Marfan slit. Moving on to the chondrocostal portion. This portion consists of an osseous segment and an aponeurotic segment. On the osseous segment, the diaphragm attaches to the internal surface of the last 6 ribs. On the 3 lower ribs, the attachment is purely costal. On the 3 upper ribs, the attachment is chondral. This chondrocostal portion is separated from the sternal portion by an opening called the Larrey slit or costoxiphoid hiatus, through which the internal thoracic artery passes. Now the lumbar portion. This portion consists of a medial segment. It is known as the pillars of the diaphragm. These pillars are located on either side of the midline and insert on the anterior surface of the lumbar vertebrae and the intervertebral discs. We can describe main pillars and accessory pillars. The right main pillar inserts on the anterior surface of the first 3 lumbar vertebrae and the intervertebral discs. Meanwhile, the left main pillar is smaller and less powerful and inserts on the anterior surface of the first 2 lumbar vertebrae. Each pillar ascends obliquely forward and upward, uniting with the opposite pillar in front of the aortic orifice to form the median arcuate ligament. The 2 pillars cross their internal fibers at the midline, forming a raphe, the fibrous bed of the aorta. The lumbar portion consists also of a lateral segment, also known as the diaphragmatic arches. These arcuate ligaments are 2 in number and are primarily part of the aponeuroses of the lumbar muscles. The psoas arch, or internal arcuate ligament, stretches from the lateral side of L2 to the base of the costal process of L1. And the quadratus lumborum muscle arch, or diaphragmatic cinched ligament, forms a fibrous bridge, extending from the summit of the costal process of L1 to the summit of the 12th rib. The fibrous bundle detached from this arch ascends to insert on the posterior edge of the lateral leaflet of the central tendon. This bundle is sparsely distributed in its middle part, creating a true hiatus or costolumbar hiatus of Henle. Moving on now to the phrenic center. The central tendon of the diaphragm is a thin aponeurosis, pearly white and shiny in appearance. It is trefoil-shaped, with 3 leaflets. Ventral, right, and left. The central tendon is made up of 2 types of fibers. Fundamental fibers, originating from various fascicles, these fibers are directed towards the anterior leaflet and the lateral leaflets. And association fibers, condensed into 2 bands. Upper semicircular band, stretched from the right leaflet to the anterior leaflet. and a lower semicircular band, stretched from the right leaflet to the left leaflet. We'll tackle now the orifices of the diaphragm. There are three main orifices. The foramen of the inferior vena cava, located in the phrenic center, where the inferior vena cava passes. It is projected at the level of the T8, T9 intervertebral disc, and is also traversed by branches of the right phrenic nerve. The esophageal hiatus is positioned at the middle of the muscular fibers, and is projected at the level of the T10 thoracic vertebra. It allows the passage of the esophagus, and also for the right and left vagus nerves. And the aortic hiatus, bounded by the body of the T12 vertebra and the median arcuate ligament. It allows the passage of the aorta and the thoracic duct. The accessory orifices are all vascular and nerve-related. The anterior orifices are the Marfan slit, retroxiphoid, located between the sternal fascicles of the diaphragm. It is avascular, and no structures pass through it. And the Larry slit, between the sternal and chondrocostal portions, it allows the passage of the abdominal branch of the internal mammary artery. The posterior accessory orifices are located between the pillars and the arcuate ligaments of the lumbar portion, and they are between the main and accessory pillars. A medial hiatus allows the passage of the greater splanchnic nerve and the internal root of the azygos veins. Between the accessory pillar and psoas arcade, a lateral hiatus contains, from top to bottom, the lesser splanchnic nerve, the inferior splanchnic nerve, and the sympathetic chain. Under the psoas arcade, the ascending lumbar vein ascends between the two planes of the psoas. And in the costal lumbar hiatus, the lymphatic trunks and connective tissue facilitate communication between the subpleural and retrorenal spaces. And the lateral accessory orifices are located between the different chondrocostal fascicles, allowing passage for the intercostal nerves, from the 7th to the 11th. Let's explore now the anatomical relations of the diaphragm. The superior or thoracic surface is in contact at the center with the pericardium, and at the periphery, with the diaphragmatic pleura. The inferior or abdominal surface is largely covered by the peritoneum and is in contact with the following structures. On the right, the superior and posterior surfaces of the liver. On the left, from the medial portion to the lateral portion, it is in contact with the abdominal esophagus, the greater curvature of the stomach, the left lobe of the liver, the spleen, and the left colic flexure. Let's tackle the vascularization, innervation, and lymphatic drainage system of the diaphragm. Starting with the arterial vascularization. The arterial vascularization originates from four sources. Superior phrenic arteries, branches of the thoracic aorta, supplying adjacent parts of the diaphragm. Inferior phrenic arteries, branches of the abdominal aorta, providing branches to the inferior surface of the diaphragm. Internal thoracic arteries, each gives rise to the pericardiacophrenic and musculophrenic arteries. And the last five intercostal arteries supply the periphery of the diaphragm, whilst the veins follow the arteries and drain into the subclavian veins or the azygos system. The diaphragmatic lymphatics form two networks. On the superior surface, called supradiaphragmatic network. Anteriorly, drains into the prepericardial lateral nodes, and the mediastinal lymph nodes. Posteriorly, drains into the periesophageal nodes and juxta-aortic lumbar nodes. On the inferior surface, also called the subperitoneal network, subdiaphragmatic drainage is done by the inferior diaphragmatic nodes. and the juxta-aortic lymph nodes. The transdiaphragmatic drainage connects to the juxtaphrenic nodes and the retroxiphoid nodes. Now let's discover the innervation of the diaphragm. The motor innervation is controlled by the right and left phrenic nerves, which originate from the cervical plexus. They travel through the supraclavicular region, anterior mediastinum, and spread across the superior surface of the diaphragm. Each phrenic nerve gives off 3 branches, an anterior branch, that supplies the sternal and anterior chondrocostal portions, a lateral branch, that supplies the lateral chondrocostal portion, and a posterior branch, that supplies the diaphragmatic crura or pillars. And the sensory innervation is provided by the last 6 intercostal nerves. Let's explore some clinical applications. For example, the diaphragmatic paralysis. It is paralysis of one half of the diaphragm, or hemidiaphragm, occurring due to phrenic nerve damage. It can be detected radiographically by observing its paradoxal movement. In congenital diaphragmatic hernia, a portion of the stomach and intestine herniates into the thoracic cavity through a defective posterolateral area of the diaphragm. It most commonly occurs on the left side. To conclude, the diaphragm is a vital muscle in humans. It plays a primary role in inspiration and a secondary role in the resistance of the abdominal wall. Its pathologies are varied, as are its diagnostic methods, which highlights the importance of understanding its anatomy.